is due to the recapture or reuptake by the active transport of norepinephrine previously released into the extracellular fluid. See, whenever the stimulus come at the exoplasmic reticulum, then it is going to cause the exocytosis of the norepinephrine containing vesicles and a massive release of the norepinephrine occurs. But totally it's impossible, unlike the acetylcholinesterase, to break down norepinephrine to the metabolite. Here, an important step is there, that's known as the reuptake of the norepinephrine with active transport with the help of the energy. It is going to be uptaken from the exoplasmic terminals, and two processes are there, uptake. So this is known as the uptake 1 and uptake 2. They are known as the uptake 1 and uptake 2. The thing is uptake across the exoplasmic membrane from extracellular fluid to the cytoplasm, especially the neuroplasm. So whenever the action potential comes and a massive norepinephrine is released into the from the storage vesicle inside the synaptic cleft, there even though the catechol O-methyl transferase enzyme is present, just like acetylcholinesterase, it is not so strong and very specific to that of the acetylcholinesterase. So the huge quantity of the norepinephrine released is reuptaken back into the cytoplasm, then uptaken from cytoplasm into the storage vesicles, especially the vesicles. The first one is uptaken into the exoplasmic membrane from the extracellular fluid to the cytoplasm. That's the uptake 1, whereas the uptake from cytoplasm into the storage is known as uptake 2. And the storage of the catecholamines. So as usual, the norepinephrine and epinephrine are stored in vesicles to ensure their regulated release. Why the storage is required? Because whenever the action potential arrives, it is not easy to synthesize the norepinephrine or epinephrine so fastly. So they need to be stored for the release whenever the action potential comes or whenever there is requirement of the neurotransmitter. And this storage decreases intraneuronal metabolism of the transmitters as well as their leakage outside the cell. The thing is, when they are stored in the storage vesicle, it is having the barrier so that the enzymes should not act on them. And for the uptake, it is uptake 1 of the catecholamines is a ATP dependent process, so that the chromaffin granules, especially in case of the adrenal medulla, the uptake of catecholamines and ATP into isolated chromaffin granules driven by pH and potential gradients are established by an ATP dependent proton translocase. So here two neurotransmitters are there, or catecholamines. One is norepinephrine and epinephrine. Norepinephrine is the one which is going to be stored in the storage vesicles in the nerve endings, whereas the epinephrine is going to be stored in chromaffin granules. For every molecule of amine take-up, 2 hydrogen ions are extruded out. So for every single molecule of the norepinephrine or epinephrine, whatever it may be, taken up, 2 hydrogen ions are extruded out. And monoamine transporters are relatively promiscuous and capable of transporting dopamine, norepinephrine, epinephrine and serotonin. All these neurotransmitters are being transported by the monoamine transporters, and they are not so specific. They are going to transport each and every enzyme, just like the monoamine transporter 1, 2, 3, etc. And dopamine, norepinephrine, epinephrine and serotonin, all these neurotransmitters are being acted by the monoamine transporters. So reserpine is a drug that inhibits monoamine transport into vesicles, which ultimately leads to depletion of catecholamines from sympathetic nerve endings and in the brain. So, reserpine is a drug obtained from the plant Rauwolfia serpentina, and it is the antihypertensive drug. So, what is the mechanism of reserpine is, reserpine is going to inhibit monoamine transporter into the vesicles, which ultimately leads to depletion of the catecholamines from sympathetic nerve endings and in the brain. So because of both of this combined effect, there is decreased blood pressure occurs, especially if you consume the reserpine. The amine transport system across exoplasmic membrane is sodium dependent. So the amine transport system in the exoplasmic membrane is sodium dependent, and this is blocked selectively by a number of drugs including cocaine and tricyclic antidepressants such as imipramine. So cocaine is an addictive drug. It is going to block the transportation of the norepinephrine from the exoplasmic membrane. So, and apart from this one, the tricyclic antidepressants such as imipramine, desipramine and tranylcypromine, these are going to this bind with the transporter system and prevent the transportation of the norepinephrine into the cytoplasm. And high affinity transporters have been identified now, for example, for dopamine, norepinephrine and serotonin, and a variety of the amino acid transporters. And why we are learning especially all these enzymes and the precursors and so many is, so to find a pharmacological agent which can intervene with that of this normal physiological process, so that we can get a required pharmacological and therapeutic effect. So that's how the purpose of learning this particular what you call as the metabolism, storage, etc. in a very specific manner. Ephedrine, amphetamine and tyramine are indirectly acting sympathomimetic amines. Ephedrine, amphetamine and tyramine, which are indirectly acting sympathomimetic amines, act by displacing norepinephrine from nerve endings, binding sites to the extracellular fluid. So what happens this, whenever we administer ephedrine, amphetamine, tyramine to the living organism, these are known as the indirectly acting sympathomimetic amines. So what they are going to do, they are going to displace the norepinephrine from the nerve ending binding sites to the extracellular fluid, and the released endogenous transmitter then acts at the receptor sites of the effector cells. And this is known as as such the agents are substrate for uptake 1. Uptake 1 means transportation of the catecholamines from the exoplasm to the storage vesicles. That's known as the uptake 1. And these actions of indirectly acting sympathomimetic amines are associated with the phenomenon of the tachyphylaxis. Tachyphylaxis means as the quantity of the neurotransmitter is going to be increased, instead of increasing the response is going to be decreased. That is known as the tachyphylaxis. And repeated administration of tyramine, ephedrine, amphetamine and tyramine, which displace the neurotransmitter from the binding site, causes the rapidly decreasing effectiveness, whereas the repeated administration of norepinephrine does not reduce effectiveness, and in fact it reverses the tachyphylaxis to tyramine. So the tyramine, which is what you call as the indirectly acting sympathomimetic amines, they are going to act or displace the norepinephrine from the binding site, whereas the uptake 2 is not inhibited by the imipramine or cocaine, because uptake 2 is happening from the exoplasmic to storage vesicle. Uptake 1 from the what you call as the intracellular fluid to the exoplasm, that transport. This is inhibited by the ephedrine, amphetamine and tyramine, whereas and also the cocaine, and uptake 2 is not inhibited by imipramine and cocaine. Then the release of the acetylcholine, not the catecholamines, in the adrenal medulla, because adrenal medulla do contain lot of the norepinephrine in the bromophenol granules. The triggering event is the liberation of acetylcholine by the preganglionic fibers and its interaction with nicotinic type of the receptor on chromaffin cells to produce. See, the nicotinic type of the receptors are present on the chromaffin cells, nicotinic acetylcholine or muscarinic type of the nicotinic type of the receptors are present on the chromaffin cells, and the liberation of acetylcholine by the stimulation of preganglionic fibers will going to cause a localized depolarization, entrance of calcium into these cells, which extrusion by exocytosis of the granular contents. Means the granular content is having epinephrine, ATP, neuroactive peptides or their precursors and chromogranules. So these are all the content of the chromaffin granules along with the epinephrine. So all these are going to be released at the same time along with the epinephrine and going to act on the receptor. So what happens? The subsequent events are the yes, whenever this type of this content of chromaffin cells along with the other additional things, especially the calcium entry occurs, localized depolarization, and all the other neuroactive peptides or their precursor chromogranins and dopamine beta hydroxyls. All these are simultaneously released. So what happens is there will be an increase in dopamine beta hydroxylase and chromogranin release in the circulation. So adrenergic fibers can sustain the output of norepinephrine during prolonged periods of stimulation without exhausting their reserve supply, provided synthesis and uptake of the neurotransmitter are unimpaired. Means the adrenergic fibers can sustain the output of norepinephrine during the prolonged period of stimulation. Continuously, if you are stimulating the adrenergic fiber, then what happens is without exhausting their reserve supply, they are provided with synthesis and uptake of the transmitter. They are not impaired. And there will be activation of tyrosine hydroxylase and dopamine beta hydroxylase, DBH, and dopamine to norepinephrine is going to be catalyzed. And terminations of the action of the catecholamine occurs. Ultimately, the action of the norepinephrine and epinephrine are terminated by the number one, reuptake into the nerve terminals. Maybe uptake 1 and uptake 2, reuptake of the nerve terminals, and dilution by diffusion out of the junctional cleft and uptake at extraneuronal sites. See, the first one is reuptake into the nerve terminals. Second one is dilution of that particular neurotransmitter vicinity by diffusion to the adjacent or junctional cleft and uptake at extraneuronal sites. Then the third one is the metabolic transformation. That means the norepinephrine or epinephrine, they are converted to their respective metabolites, like just like normetanephrine and metanephrine. And here two important enzymes are having the metabolism of the catecholamines. The number one is MAO or monoamine oxidase is the important enzyme, followed by catechol O methyl transferase, which is also known as COMT. So these two enzymes are very important in the metabolism of the catecholamines. However, it is evident that a powerful enzymatic pathway such as the provided by acetylcholinesterase is absent from the adrenergic nervous system. So whatever may be, these two enzymes are present, but they are not as strong as acetylcholinesterase, which is present in the cholinergic nervous system. And these are not so strong when compared to the acetylcholinesterase, which is going to metabolize the acetylcholine into acetic acid and choline. So in a flash-like manner, that's very strong enzyme, whereas the monoamine oxidase or catechol O-methyl transferase are there, but they are not so effective as acetylcholinesterase. And the norepinephrine released in nerve terminal is metabolized by the monoamine oxidase. Norepinephrine released in nerve terminal is is metabolized to, it is what you call as, it's metabolized to the water soluble moiety and going to be secreted out. And another enzyme, that's the catechol O-methyl transferase, which converts norepinephrine to which is going to catechol O-methyl transferase is converting these catecholamines to the inactive substances like homoandrinic acids, etc., which are going to be secreted in urine, some metabolized. This is present very specifically in the liver, plays a major role in the metabolism of endogenous circulating and administered catecholamines. So if you exogenously administer certain norepinephrine or epinephrine, then the catechol O-methyl transferate, it is going to be activated, then it is going to decrease the concentration of the enzymes, especially the norepinephrine. And both monoamine oxidase and catechol O-methyl transferase are widely distributed throughout the body, including inside the brain. And highest concentration of each are present in the liver and in the kidney, especially the monoamine oxidase and catechol O-methyl transferase. Both are present in the liver and also in the kidney, and also they are also present especially in the nerve endings, in the synaptic cleft. Catechol O-methyl transferase or COMT plays minor role in adrenergic metabolism. So even though it's an enzyme which is present in the adrenergic nervous system, its role is minor, unlike the acetylcholinesterase, which is one of the major what you call as the enzyme which destroys the acetylcholine within a fraction of seconds. It is not like that. It is not so important. And two different isoenzymes of monoamine oxidase are found in the central nervous system and in the peripheral nervous system. So subtypes of the monoamine oxidases are present and subfamilies are also present. Epinephrine and norepinephrine are methylated by catechol O-methyl transferase to metanephrine and normetanephrine respectively. Then they are going to be converted to some water soluble moieties, going to be secreted in the urine. That's how the metabolism occurs. So here, this is a very specific chart. One has to remember this particular chart. Here you can see that the norepinephrine is acted by monoamine oxidase and going to be see here, monoamine oxidase is going to act on norepinephrine and it is going to convert it to DOP-GAL, DOP, that's the short form of dihydroxyphenyl, so 3,4-dihydroxyphenyl ethylene glycol. So this is DOP-GAL, and the monoamine oxidase, especially the epinephrine, is also going to cause the DOP-GOL. Whereas the norepinephrine is acted by catechol O-methyl transferase to catechol O-methyl transferase, and the methylation occurs here and it is going to be converted to normetanephrine. Whereas the epinephrine, with the presence of catechol-O-methyl transferase, it's going to metanephrine. Whereas the normetanephrine and metanephrine both are acted by the monoamine oxidase to form the MOPGAL, MOPGAL, and both of these things, they are going to aldehyde reductase and aldehyde dehydrogenase to MOPEG and the DOPEG, which is caused by the aldehyde reductase enzyme to cause the DOPEG, and ultimately they are going to be caused this vinyl mandelic acid or the VMA and going to be secreted in the urine. So this is the what you call as the pathway how the metabolism of norepinephrine and epinephrine occurs, unlike that of the acetylcholine esterase. Two enzymes are present. Of course, the monoamine oxidase enzyme is somehow more potent than that of the catechol-O-methyl transferase, because the catechol-O-methyl transferase converts the catecholamines to metanephrine, and metanephrine is actioned by the monoamine oxidase, and MOPGAL is going to cast, and the vinyl mandelic acid and MOPEG are going to be formed. So please remember this particular chart. So norepinephrine is initially deaminated by monoamine oxidase enzyme to 3,4-dihydroxyphenyl glycoaldehyde. 3,4-dihydroxyphenyl glycoaldehyde. And then this aldehyde, especially you please see here, 3,4-dihydroxy monoaldehyde. 3,4-dihydroxy monoaldehyde. This is reduced to the glycol 3,4-dihydroxyphenyl ethylene glycol, or it's also known as DOPEG, DOPEG. This is DOPEG. Then to form later this is acted by aldehyde dehydrogenase to form 3,4-dihydroxy mandelic acid, or it's also known as the DOMA. 3,4-dihydroxy mandelic acid, or also the DOMA. Then this is generally but incorrectly called as vinyl mandelic acid or VMA. Is the major metabolite of the catecholamines. This is ultimately excreted in the urine. It is made as more polar and water soluble. The corresponding product of the metabolic degradation of the dopamine, which contains no hydroxyl group in the side chain, is homovalenic acid, HVA, and this is going to be secreted in the urine. And the measurement of the catecholamines and their metabolites in the blood and urine is useful in the diagnosis of pheochromocytoma, a catecholamine secreting tumor of the adrenal medulla. So suppose there is a tumor like pheochromocytoma, then the metabolite concentration will be measured in blood. Then it is an indicator of the tumor. And inhibitors of MAO like pargelin and nialamide can cause increase in the concentration of norepinephrine, dopamine, and 5-hydroxytryptamine in the brain and other tissues, accompanied by varieties of the pharmacological effects. Whereas no striking pharmacological action can be attributed to inhibition of COMT. That means it's not an important enzyme. Just if you compare to the acetylcholine esterase enzyme, so it is present but not so important, especially in case of adrenergic nervous system. The enzymatic degradation is not so important, whereas the uptake and other processes are somewhat important for the metabolism of